Hello, I'm Michael Pinsky, and this is a lecture on the use of artificial intelligence in acute care by redefining health and disease. These are my important conflicts of interest, and these are my unimportant conflicts of interest. But one that is very important to you is that we have a patent on the system and method of determining susceptibility to cardiorespiratory insufficiency, and we use that in this presentation. Okay. Artificial intelligence is a healthcare tool. It's already here, and it's affecting what you see and how you can practice. So understand how to optimize its usefulness. In a simplistic approach, you can use AI as a co-pilot. It basically reminds you when you're supposed to remove a Foley catheter, or these two antibiotics are having the same effect, or can both cause renal failure, or whatever. And they can determine the proper dose of insulin or weight-based heparin, etc. Okay. This is good for routine alerts to remove devices not needed, and they can also worry about acute kidney injury, dangerous drug interactions. And furthermore, we can use them to look at existing patterns in disease. For example, there is a thing called a sepsis sniffer, and we've created one ourselves, which lets you know that this patient looks like they're going into septic shock. And there's also one that's commercially available that tells you that you have a risk for coronary artery disease, acute coronary insufficiency. Okay. And these things exist today. Okay. So when we think about how we're going to assess health and disease, it has to be defined over time. So it is a time-space continuum. You don't just look at a static point in time of a patient, but you look at them and how they're evolving. But if you want to look at them at a static point in time, you can say, what is the risk the patient has right now, what's going on, when I just take a snapshot? A more relevant way to do it is to look at the dynamic changes in the patient over time. Are they getting better? Are they getting worse? Because the two patients have the same basic value. One is getting better and the other is getting worse. Even though they start from the same point, I bet they would have different outcomes. So the problem with looking at things simply as what does the picture look like is because you like to look at things in a static way. It's the normal way people work. The problem is that biology is not static. It is chaotic. And chaotic, I mean, it's nonlinear. It has a fractal appearance, and one has to use nonlinear thinking to be able to solve many of the problems that we see in medicine. An example of a linear system is a screw or a bicycle. You put in a little, you get out a little. You put in a lot, you get out a lot. And it can be really complicated and complicated man-linked systems, but it's only half the picture. Natural systems are nonlinear. They are fractal in nature, meaning self-similarities around all levels. They define minimal organizational rules and nothing else. They take care of themselves. They're deterministic and they're self-organizing, thank goodness. And they adapt easily to external stress without doing anything. And similar inputs, and this is important, can have much different effects on two different patients depending upon their initial state. It's the fact that we have fractals that we now understand how the capillary system, once it leaves the large arteries in the heart, work. It was only after we had fractal systems that we were finally able to understand pulmonary blood flow gas exchange units. Complex systems are self-organizing, and it's the self-organization that allows them to survive. When you look at a termite cathedral, it's only created by termites that use 3 simple rules. And every termite cathedral looks different, but every single one of them has the same basic structure. Just like all trees look different, but you recognize the tree when you see it. This is an example of a thermal scan of a petri dish of log growth E. coli. And you will notice that the E. coli have lined themselves up in clear orders. We didn't tell them to do it. They did it on their own. This is the same petri dish heated to 40 degrees. Fever abolishes the ability of E. coli to autoregulate and is probably one of the reasons why humans and other warm-blooded animals get febrile when they're infected. It is a way of fighting infection. Okay, so the problem is we can't look at things very well ourselves. We have a cognitive limitation. Let me give you a couple examples. This is a vase. You cannot look at this picture of an outline of a vase and see the two outlines of people looking at each other at the same time. You can either see the two people or you can see the vase. You can't see them simultaneously. Furthermore, this is a picture in which I'm showing you a bunch of graphs, and the lines in the center, the black lines, are straight. I assure you, those lines are absolutely straight. But when you see them, they look like they're curved. So the problem is that you can't predict things on your own. But don't be surprised by the unexpected. Prepare for it. But can you predict it beforehand? Okay. Well, let me show you an example. This is a picture of the night sky. I didn't change the night sky. I didn't even change how you look at it. I'm just looking at the same picture over time with a delayed exposure. And when you look at the dynamic changes over time, emerging patterns occur which were right before your eyes. Okay. So let's look at examples of heart rate variability. We had a series of patients that we studied and published years ago by Fumi Agandelli on the right and Gilles Clermont on the left, and myself. And what we did is we had a series of patients who we knew crashed, and they crashed on the right, at this point right here. And we had another series of patients who were stable. And we trained a model on what were the signatures of heart rate variability in them that predicted instability in both groups. And then we followed them back 6 days. And as you can see, the patients who were not going to crash fully separated from the patients who would 2 days before they crashed. And what was happening was their level of heart rate variability, the randomness in their heart rate, was going down. Their heart rate was becoming more stable. Stability in biology is not a good thing. You want variation and randomness. I assure you, there's nothing more stable than death. So let's identify health and disease as the dynamic continuum between the various forces. We looked at this in patients who were brought into the step-down unit and subsequently developed acute cardiorespiratory insufficiency, and some that didn't. And we brought them in and we looked at them at data collected after 15 minutes, for just 15 minutes, once they were admitted to the step-down unit. And we knew later if they crashed or didn't. We were able to identify that those patients who were subsequently going to crash maybe a day, a week later, clearly separated out from those that didn't. 80% of the patients who we brought into the hospital, we could identify as never crashing with a false negative rate of 1 in 10,000, meaning we were only wrong 1 in 10,000 times. That's triage. When you look to see what happened to them as they then crashed, clearly they were getting unstable much more as they went towards the moment of crashing, but of course they were already unstable before. Could we make it better? So what we did is we forced all of them, even though we knew which was bad and good. We said, everyone, I don't care if your respiratory rate is 30, you've got interstitial fibrosis, so it's going to be 30 the rest of your life. We're calling that normal. And we did that and we normalized them to where they were. And then we looked at what happened when they crashed. We were clearly able to identify when they were crashing 90 minutes ahead of time with a very, very low false positive rate. So if the machine went beep, almost all of them were identified. Now, but once you've resuscitated a patient, you need to know when to hold, when they need no more norepinephrine increases, no more boluses of fluids, when are they sufficient? And we were able to identify true positive rates extremely well with personal baselines, here shown in green, and without baselines, we had a lot of data in yellow, in blue. And thus, you can actually know when to hold. And this is important going forward. So I can capture these concepts and apply them at the bedside. And that'll be briefly demonstrated here on using the admissions to the hospital that I just showed you, clinically relevant tachycardia, clinically relevant hypotension, and the identification of sepsis. There are many ways that cardiorespiratory deterioration occurs due to the autoregulatory controls that the body has. However, there are only a certain number of paths that can be defined. When we looked at the patients who had a cardiovascular insufficiency, as shown in the previous slides, we could divide them into 5 subgroups that had clear different pathways to deterioration that were easily identifiable more than 6 hours beforehand, as compared to those that never got deteriorated. And those are the non-deteriorating patients are those that are shown in the gray padded line. And when we looked at a large database of patients to identify any tachycardia, it was pretty easy to separate them. The cases here are shown in blue. The probability of risk goes up and up to the time of the tachycardia event. And more importantly, the first event of tachycardia, which if a person's already had tachycardia once, they're very likely to have it again. But as you can see, we can still identify when a patient would have tachycardia well before it happened with a very high degree of confidence. Similarly, we could have the same ability to identify hypotension compared to non-hypotension in a similar database. Unfortunately, we were much better at determining who would always be stable than we were on patients who eventually got stable. Still, there was a clear separation between those who would become unstable, and shown here in red, and those that were going to remain stable, shown in blue, 60 minutes beforehand. We then looked at the University of Emory in Georgia, their data on predicting sepsis, and we found that we could have a very good area under the curve of predicting sepsis up to 36 hours before it happened. This slide demonstrates a time series of 20 hours in one patient with the model output of guessing the probability of sepsis on the top, mean arterial pressure, pulse at arrival time, heart rate variability, and heart rate as the metrics. As you can see, the model didn't hear anything right away, but heart rate variability, shown here in panel D, started to fall. Importantly, the model started to pick up that there was a probability of sepsis coming on when the pulse arrival time fell. And that's important because peripheral vasodilation is one of the earliest manifestations of establishing sepsis that we see. So the implications of this robust intelligence system, which we call IQ, are that it's a force multiplication in all echelons of care, no matter where you are. Less qualified staff can now be effectively monitoring the patients without significantly advanced training. They just know that they need to alert people quickly, and the people that are advanced know when to come. This is excellent, therefore, for disasters and the overwhelming pandemics that we've recently seen. What it does is it allows for standardization of care in a personalized fashion per patient. It doesn't make every patient's care identical. And this, by the standardization of care practices, simplifies resources needs and reduces inappropriate care because treatments are not given to patients who do not need them. The nice thing about using machine learning is as more data comes in and more treatments become available, the machine learning adapts easily to those because over time it wants to evolve to be the best provider of care. So we developed this graphic user interface that gives us an index, a PIT index of IQ. And PIT stands for predicting instability, time, and treatment. And what you see at the top is the probability of the event. On the bottom, the time to the event. And then a classic time series analysis of heart rate, respiratory rate, and O2 sat, plus the index of how it goes up, color-coded for the degree of severity, and then a prediction of when crashing is going to occur. In this case, 7 minutes from now, it'll be a fall in SpO2. And finally, on the right side is the cardiovascular status of the patient and which processes are primarily determining the state at the moment. And what happens is when you start treating the patient, the probability of the event falls and you run away from the time that it will occur. So the future of hemodynamic monitoring is We're going to monitor the monitors, but treat the patients. We will use robust artifact detection to increase the value of the alerts and reduce alarm fatigue. And what we're going to be using are fuse parameters. Yes, we'll look at tachycardia and hypotension and SpO2 falls, etc., but we'll use parameters that'll be showing abnormality long before these specific ones fall into dysfunction. And by scaling the monitor devices and sampling frequencies based on the severity and changes necessary, we can efficiently manage patients with the least amount of excessive use of monitoring resources. So with that, I hope I've given you an overview of some of the exciting areas where artificial intelligence directly impacts with patient care in critical care medicine. Thank you very much for your attention.